Good afternoon. Not having a quorum yet, but we will go ahead and get the meeting ready to go. And we have a full agenda today, so we appreciate all of you being here, both our testifiers and those who are here to listen. And as soon as we do have a quorum, staff will let me know, and then we'll act and interrupt proceedings to act on the minutes in the and call the meeting officially to order. So, all right. I'm informed we do have a quorum, so we will officially call the meeting to order with our quorum. Thank you very much. We'll just go ahead and take our business at hand. Then we have minutes. Okay, we have the minutes from February 9th, so moved by Representative Hamilton. Thank you. Any discussion or changes? Seeing none, we'll proceed to a vote. All those in favor say aye. Aye. Opposed? Motion prevails and is adopted. I'll now take a motion for the minutes from February 14th. So moved. Moved by Representative Liebling. Any discussion? All those in favor say aye. Aye. Opposed? Motion prevails and the minutes are adopted from February 14th. Thank you very much, members. Get that business taken care of before our testifiers get in the swing of things. We have an agenda this morning. First one is Mayo and University of Minnesota Biotechnology and Genomics Partnership. Very welcome to the committee. Appreciate your being here today. Just want to let you know we've allotted a total of 15 minutes, so if your testimony is under those 10 minutes, it gives a little more time for some of those questions as well. And so with that, for the record, if you just state your complete name, if it is already printed on the agenda, you don't need to spell it. If your name is not printed on the agenda, would you please go ahead and say your name, your title, and the organization you might be with. And with that, who's starting today?
Hi, Madam Chair. I'm David Utzweiler.
Welcome, Dave.
I am the Executive Director of the Decade of Discovery in Diabetes. And Madam Chair and members of the committee, thank you for the opportunity to be here this afternoon. The Decade of Discovery is led by the University of Minnesota and the Mayo Clinic and is focused on the goals of preventing, optimally treating, and ultimately curing type 1 and type 2 diabetes. The initiative is a project of the Minnesota Partnership for Biotechnology and Medical Genomics, which was founded in 2003 with the purpose of combining and leveraging the research of the university and the Mayo Clinic through a high-powered collaboration. Since its founding, the partnership has become a globally recognized model of collaboration in biomedical research. After establishing a track record of success 18 months ago, partnership leaders were challenged to raise the bar on what they could do to make a transformational difference with a major disease. Based on a thorough review of institutional and state assets, diabetes was identified as the research area that offered the greatest promise for a major breakthrough. They believed then, as we do now, that we can radically improve the health of Minnesotans, dramatically reduce costs borne by public and private payers, and affirm Minnesota's position as a leader in health-related economic development. Diabetes is a growing epidemic with devastating health and financial impacts. Nationwide, 1 in 10 adults has diabetes, and experts predict nearly 1/3 of the U.S. population will be affected by the disease by 2050. In Minnesota, more than 1 in 3 adults and 1 in 6 youth have diabetes or prediabetes, and diabetes is the 7th leading cause of death in the United States and a major cause of heart disease, kidney disease, amputation, blindness, and stroke. Medical expenses for people with diabetes are more than twice the amount as those for people without the disease. 1 in 3 Medicare dollars is spent on diabetes, and in 2007, the estimated cost of diabetes-related medical expenses in the U.S. was $174 billion a year. In Minnesota, it was nearly $3 billion in that year. The United States needs strong leadership to tackle this problem, and Minnesota can and will provide it. Minnesota is uniquely positioned to achieve the breakthroughs required to stem this tide. And our history is filled with accomplishments in diabetes research, and our strengths are innumerable. outstanding providers, a rich public health tradition, engaged community and patient advocacy organizations, and a world-class biobusiness industry. Decade of Discovery is joining and leveraging Minnesota's unique strengths and assets to conquer diabetes. We are engaging partners from across the state's healthcare, insurance, business, public health, patient advocacy, and consumer and information technology sectors. Together, we are identifying ways to prevent diabetes, serve those with the disease, and ultimately find breakthroughs that will lead to cures. The benefits of achieving this goal are significant. First, Minnesotans working together will improve public health by transforming the lives of people with diabetes. Second, we will deliver multi-billion-dollar savings to our healthcare systems and to employers by reining in the significant costs associated with diabetes. Finally, we will affirm Minnesota's position as a leader in health-related economic development, creating new businesses and jobs from our research that further elevates Minnesota's reputation as a major healthcare center. I now turn the floor over to Dr. Aaron Friedman, Vice President of Health Sciences and Dean of the Medical School at the University of Minnesota.
Dr. Friedman, welcome.
Thank you. As David mentioned, I'm Aaron Friedman. I'm the Vice President for the Health Sciences and Dean of the Medical School, and I thank you, Madam Chair, and the members of the committee for this opportunity. As you heard, the Minnesota Partnership was launched in 2003, and it began a new era of collaboration for both the University of Minnesota and for the Mayo Clinic. Now, research is the core of the partnership, and one of the pillars of that research is the decade of discovery. So research was focused not only on the decade's ultimate goal of curing type 1 and type 2 diabetes, but also driving the near-term objectives of prevention and optimal treatment. One of the unique aspects of the collaboration between the two institutions is the coming together of researchers for different disciplines. In December, the decade announced funding for 3 landmark research projects, all of which focus on different areas of making a difference in the lives of people with diabetes. These projects advance the work on an artificial pancreas. They also are working on anti-obesity drugs and on exploring immune-based diabetes treatments. While each of these projects holds promise for improving the lives of what is now 1 in 10 Americans, adults who are living with diabetes, I'd like to focus on one of them, the work to further develop an artificial pancreas. Mayo Clinic diabetes researchers Yogesh Kudva and Anandu Basu have joined a University of Minnesota electrical and computer engineering professor, Stephen Kester, in developing a specialized electronic chip that will improve glucose monitoring and provide what's a critical component to the artificial pancreas under the development at the Mayo Clinic. The chip will transmit data wirelessly and function in more locations around the body and last longer than any current sensor. This device is crucial to being able to create an artificial pancreas which can respond in real time to glucose levels in the body. By advancing the development of an artificial pancreas, the research project exemplifies how broadly and profoundly the decade will impact Minnesota, improving the health of Minnesotans with diabetes, reducing costs to the state and its businesses, spurring economic development. The decade is Minnesota's next milestone in its world-renowned leadership in improving health both here and around the world. I'd like to turn to my Mayo Clinic colleague, Dr. Ziegenfuss, to share with you some of the exciting work taking place to improve diabetes prevention and treatment today.
Welcome, Dr. Ziegenfuss.
Thank you, Dr. Friedman, Madam Chair, members of the committee. I'm here to explain 2 major projects the Decade of Discovery has launched to aid diabetes research and care delivery in Minnesota. These projects are a critical first step in our process of identifying and supporting statewide deployment of best practices in prevention and care to improve health care and direct cost savings. The first is the Minnesota Health Atlas, a publicly available online resource that serves as a single destination for information on diabetes and the health of Minnesotans. This resource will help physicians and others provide with prevention and care strategies. The information included in the Atlas's maps, tables, and charts enables stakeholders to monitor diabetes indicators and population health to identify trends and evaluate interventions, and to identify areas of need to inform proposed prevention and care strategies. Currently, the Atlas contains a broad range of public health, state, and federal data on diabetes in the state. And we are building partnerships to incorporate more unique data sources. We also have aggregated the data to the county level and provide in it maps that can be easily downloaded by users. The other resource created by the Decade of Discovery is a statewide diabetes inventory, which provides a baseline of healthcare and prevention interventions that are now being used to reduce the impact of diabetes in Minnesota. This statewide census of activities surrounding diabetes care delivery will provide a central resource to help foster innovation and collaboration that will be helpful to all diabetes stakeholders and raise the standards of care received by Minnesotans with diabetes by providing a baseline of care delivery in the state, allowing for measuring improvements, creating the opportunity for conducting demonstration projects, identifying collaboration and communication opportunities among stakeholders to encourage information sharing and shared success. This information will ultimately be placed on top of the Atlas, if you will, to provide an excellent population-based foundation. Both of these tools will be used to evaluate not just statewide, but local studies and outcomes. They will also allow local public health agencies to demonstrate and measure disparities in treatment. By partnering with other entities and ensuring all information is pre-consented, our collaboration can make great strides by having all that we can know about diabetes in Minnesota in one place. Using these tools to know what we know and provide a baseline for the state will allow us to keep an accurate scorecard for discoveries and improved care as we move forward in the decade. Thank you.
Thank you, Dr. Zingenfuss. And by the way, for the record, would you just state your name just for the tape?
Yes, Jeanette Zingenfuss.
Thank you very much. I appreciate that. We have it in writing, but staff, so we need to have it on the tape as well. Thank you. Thank you very much for your presentation. Lots of new things, and we're very pleased to know that Minnesota is in the forefront of this work. Members, are there any questions for our testifiers today? Representative Lomer.
Thank you, Madam Chair. Yes, I was just curious how the Supreme Court's decision, I don't know who wants to answer this, but on the newborn blood spots has affected your genetic research. Has it affected it in any way?
Dr. Friedman, it looks like.
Are you referring specifically to diabetes in your question?
Representative Lomer.
Thank you, Madam Chair. Not specifically, but just
So
either way, if
Friedman?
maybe it
Thank
doesn't
you.
apply then.
Thank you, Madam Chair. I think that we're still, like everybody else, trying to figure out what this actually means. You may or may not know this, but I'm a pediatrician. So the specifics of that decision for those of us who have taken care of newborns is one that remains to be seen. But it is, to some extent, for those of us who take care of newborns and would like to be able to do an even better job, does present some logistical problems.
Thank you, Dr. Friedman. Representative Lomer. Anybody else with a question? All right. Thank you so very much. A very interesting presentation. We look forward to more good work. Thank you very much. All right. Next, we're going to have the Minnesota waiver update. And we'll give our testifiers an opportunity to come to the table. Well, welcome. Today, again, the subject is Minnesota waiver update, and we have Jean Wood and David Godfrey and Idil Abdul are on this part of the agenda. But again, for the tape, not just for the printed record, for the tape, again, state your name and title.
Madam Chair, for the record, my name is David Godfrey with the Department of Human Services.
I am Jean Wood with the Department of Human Services.
Madam Chair, members, I will begin with an overview of where we're at with the waiver process as a whole throughout the agency, and then I will turn it over to Ms. Wood to describe the status of the continuing care administration proposals. As you all know, we've been here to testify, I think, late last year about the MA reform effort. We, at that time, talked a lot about the content and the process of the waiver reform, and I won't go through that this time in as great a detail. What I'd like to do is just simply tell you the steps and the milestones that we've achieved with the waiver and where we're at on a number of the projects. As you know, the legislature last session passed language to have the department seek a large amount of flexibility from the federal government to reform a Medicaid program. It really has 6 primary focuses: to increase independence, increase community integration, reduce reliance on institutional care, achieve better health outcomes, simplify administration of the program and access to the program, and to create a more fiscally sustainable medical assistance program. We, pursuant to the language that was passed last session, we conveyed a report to the legislature on Monday, January 23rd. Hopefully you've all seen a copy of that. We, as of right now, are moving forward with 3 primary vehicles to seek this federal authority. The first is through application to the Centers for Medicare and Medicaid Services for a duals financing integration program that will seek to implement a managed care capitation integrated financing model for seniors that are duly eligible for both Medicaid and Medicare. That application will be submitted in mid-April. Second, we will also in mid-April have a large MA reform waiver, Section 1115 waiver, and associated state plan amendments that will go in to seek authority for the bulk of the projects that we'll mention briefly today. And then finally, we just submitted on February 13th another Section 1115 waiver to get approval for the 2,000 changes to the nursing facility level of care standards for our home and community-based waivered services programs. That waiver also seeks to get a match on a state-only program, the Alternative Care Grant Program, and also seeks to implement the Essential Community Supports Program and to seek a federal match on that state-only program as well. We did have a comment period on the 1115 waiver that ended December 28th. We received a number of comments, which we took seriously. In response to those comments, we made several changes to the proposal for the nursing facility level of care changes, both around the Essential Community Supports Program. The Essential Community Supports Program is a modest package of services that will be provided to individuals who lose state plan services in Medicaid as a result of these changes, and also who lose seniors who lose access to waiver services. One of the changes we made was to extend the ECS program to individuals who are under the age of 65 who will lose access within the next year to those home and community-based waivered services, but who remain on the state plan. And that will be for that group of that population that's currently on the program. ECS, at least in the short term, will not be extended to those in the future who would have otherwise had access to waiver services based on the old nursing facility level of care. And then also we're adding an additional benefit to the ECS program called Community Living Assistance. So going forward, I will just mention some other projects that are called for in the statute, in addition to the duals financing model and the nursing facility level of care changes. The first is around the HCDS, or Healthcare Delivery Demonstration System project, which is our ACO-like model that will be up and running after the beginning of the second quarter in 2012. We have submitted a state plan amendment for that on December 22nd, and we're in the process of having conversations about getting federal approval for that initiative. The next area is around promoting personal responsibility and to reward healthy outcomes. This, as you may know, DHS was awarded a $10 million grant for a 5-year project to implement the We Can Prevent Diabetes program, which will provide diabetes prevention program a diabetes prevention program to Medicaid enrollees in the metro area. We will begin implementing that at clinic sites beginning April 2012. And we are continuing to seek ways that we can disperse that program more statewide to parts of greater Minnesota. The next area is to encourage utilization of high-quality, cost-effective care by using cost-sharing to incentivize Medicaid enrollees to seek out care at high-quality, low-cost providers. And for this initiative, we're convening a work group with the Department of Health to come up with this proposal. The challenge with this item is that the data that's available through the peer grouping effort led by MDH won't be available until the end of calendar year 12. And it's that peer grouping data that we will be deploying in terms of identifying who the high-quality, low-cost providers are. There's also a provision to revise eligibility for adults without children by imposing a limit on assets for adults without children under 75% of poverty, and also to reinstate a 6-month durational residency requirement for Minnesota Care adults without children. This will be submitted in the larger demonstration waiver in April. Empowering, we have 2 provisions, one to empower, that come out of the Empower, Encourage Housing, Work, and Independence. One is to identify ways that Medicaid can support employment supports for certain populations, and also another related provision to seek ways that Medicaid can support housing services for certain individuals. Those will be included in the waiver that will be submitted in April. And then there are 3 items which are from the chemical and mental health area. One is to redesign the intensive residential treatment services, or the IRTS program, and that provision actually will not be included in this waiver submission in the spring. Rather, it will be dealt with in a larger planning effort that will be undertaken by the agency around all of our chemical and mental health services. We will, in the larger waiver for the spring, include a waiver of the IMD exclusion for the Anoka Regional Treatment Center, and also seek an exception to the IMD exclusion for individuals who are in IMDs who are under the age of 21. And so those are the non-continuing care provisions. I will now turn it over to Ms. Wood to describe the long-term care reform.
Good afternoon, Madam Chair and members of the committee. I am working off of this handout. So it's white with black print, unfortunately, not very colorful, but there nonetheless.
Thank you, Ms. Wood.
As you've heard from David, the legislation authorizing the MA reform waiver was passed in the 2011 special session. And so we in continuing care set out to work with our stakeholders in disability services and aging and adult services, and with our home and community-based services partner panel. And we had to start thinking about how we would reform our long-term care system. That involved both understanding how the system we have today came to be, the pluses and minuses of that system, and then imagining or visioning how we could reform the system to make it more person-centered. The end result is a vision for a system in which people get the right services at the right time. The vision is organized around 5 themes with some variation that together can support a person in a more holistic and integrated way. And those themes are navigation, self and family advocacy, prevention and self-management, in-home supports, employment supports, and housing access supports and preservation. Employment and housing are 2 themes that are addressed in other sections, in addition to the redesign of home and community-based services. So before I explain the vision for reform more fully, I'd like to talk a little bit about how the long-term care system evolved. Minnesota has made considerable progress over the last 2 decades toward balancing the state's long-term care delivery system for older adults and people with disabilities away from a largely institutional-based to a home and community-based services-based. Because of this, Minnesota is recognized as a national leader in directing more public funds to support people with disabilities and older individuals in a more cost-effective home and community-based settings rather than in institutional settings. The state also has several initiatives that encourage person-focused planning across the system and will improve the quality, consistency, and long-term sustainability of services. And examples of these reforms are return to the community, min choices, provider standards, rate setting, and long-term care consultation information. Even with these important efforts, the increasing demand for services and continuous budget constraints are driving the need for additional reform. Pressures include changing demographics as the baby boomers age, increased longevity that give us increased population over the age of 85, and increased frailty of that segment of the population. The need for increased community supports for individuals with severe and persistent mental illness to reduce the use of hospital-based services and other services outside the DHS health care and long-term care system. Increasing number of persons with disabilities, and changing expectations about services that will allow people of all ages to remain in community settings. Because the population of Minnesota is aging and living longer, the demands on the state's public pay long-term care system will be increasing at a time when resources are becoming more limited. And the federal government has shown a willingness recently to consider new arrangements with states. Now is the time for our state policymakers to pursue these new opportunities. And because of the way that Minnesota's multiple home and community-based services waivers have developed at different times, the system is hard to navigate and calls for simplification on behalf of providers, lead agencies, and recipients alike. As Minnesota has experienced expansion in home and community-based services over the last 10 years, the need for budget constraints has resulted in limits on growth. Practically, this uncertainty may have resulted in an unintentional bias toward providing more extensive benefits that may be required and may also result in people being unwilling to reduce their service utilization as their needs change. Funding limits have resulted in waiting lists and uncertainty as to whether funding will be available in the future should needs change. You have a couple of diagrams in the handout, and the first one is a triangle diagram, and that is how we see our current system. And because of history that I've described, there is a pressure for recipients to move into waivered services in order to receive the services that aren't available otherwise. So once on a waiver, a person has access to waiver-specific menu of services, and there are people with low needs and high needs, and they are all on the same waiver program. And what we are doing as a part of our reform is to try and switch this to a new conceptual framework, which is on the next page, which is more of a square. It's what we call the wedding cake. It's actually layered. And so this is a system that is flexible and fluid so that people can get a higher level of service when needed, but stay at or return to lower levels when those lower levels of services are sufficient. And as you see, there are 4 layers. The first one, bolster community and family support. And our purpose here would be to increase the availability of low-cost services and supports that prevent or delay the need for more costly and intensive long-term care services and supports for people with disabilities and older adults. The next layer are supports to maintain independence. And our intention in this area is to develop services or a benefit set that can meet the long-term care needs of individuals in their own homes, coordination of health and other needs, and ensure 24/7 awareness of the individual's situation and response to emerging needs. The third level are supports to increase independence, and our purpose there is for those who are moving out of intensive community supports, that next level, or institutional settings, be able to establish or reestablish their life in the community. And then the fourth layer are those intensive services and supports, services available to individuals who require more intensive interventions and supports, including those individuals with complex needs. These services may be long-term, they could be short-term, but needed to provide stability for an individual. So what's next? Beginning in late 2011 and extending through 2012, we have been looking at more in-depth data and fiscal analysis that will inform specific components of this reform, including the most appropriate and cost-neutral vehicles to obtain federal authority to implement the desired changes. This analysis will help identify any components that potentially could be implemented by July 1, 2012, meaning there may not be a need for a waiver, but as well the overall design in 2013, which would become a legislative proposal for this next session, implementation by July 1, 2013. It will assist in determining the staging of reform, and the transition from current to future state, while we continue to learn about the complexity and needs of those we serve. Potential vehicles, and these are defined in the appendix of your report, and they include the Community First option, another home and community-based services waiver, an 1115 demonstration waiver, MA state plan, or home and community-based services access option, also known as the 1915I. And again, these are all possible waivers and options that we have available to us now. Once we know what the system needs to look like along with our stakeholders, we would be taking the most appropriate vehicles.
Thank you, Ms. Wood, and thank you, Mr. Godfrey. And I just wanted to mention, I noticed that your arrow went both ways. I think one of the things in the I'm sure the challenges you have here is that you have seniors where you generally look at a classic moving things along that way. You have people with disabilities who start at a very intensive support and many times are amazingly independent as things go along. So it seems like what I hear you saying is that will be encourage, I think, those of us who have been around in long-term care have seen the example of a hip surgery. You go in for short-term and go back out to independence is probably the one we've all most experienced in seeing that moving along and back and forth. Representative, you have a question. I'm not quite
Thank you, Madam Chair.
Right.
I think this is appropriate. You said we've requested the waivers. When do we expect to hear back from the federal government about our requests? And what happens if they do not grant the requests? Who's affected? Will there be additional cuts, and what populations?
Ms. Wood or Mr. Godfrey?
Madam Chair, Representative Hamilton, I'll take that one. The typical time for a large 1115 waiver to be approved or to be negotiated by the federal government can really, well, it can vary, but typically it's about 12 to 18 months. We have set out a very ambitious time frame here to attempt to negotiate both, let's talk about the larger level, the larger Section 1115 waiver that will be submitted in the spring, and then I'll come back to the level of care waiver that we just submitted this Monday. But on the larger waiver, we've set out a very ambitious timetable to negotiate this between April and December of this year in an attempt to get whatever federal authority we can to come back to you at the legislature and say, here are the changes that we negotiated with CMS to our program, and if you seek to move forward with these, here are the statutory changes we need and the appropriation changes we need in order to implement them. That's our goal for that larger Medicaid waiver. On the level of care waiver that was just submitted on Monday, we have submitted that separately from this other larger effort because If we are not successful in negotiating the changes, implementing these changes with CMS, there is a 1.67% rate cut that goes into effect for all home and community-based services providers to basically buy out the money, the potential savings that were associated with those changes. And so we've tried to expedite that negotiation project by cutting it loose and sending it early. And my hope is, now that CMS has the document, that we'll be able to enter into pretty intensive conversations with them between now through April. So in the event it looks like we're not getting very far with the federal government on this, that we can come back and provide you that feedback, so you will have the option to either to address that rate cut if you so choose in some other way.
Representative Hamilton, does that answer your question?
Follow-up because of
Sure.
the response.
Representative Hamilton.
What advice or what could we be doing as legislators to assist you with communicating to our congressional delegation as well?
Okay.
Madam Chair, Representative Hamilton, having the
Godfrey.
support of the congressional delegation is very important in these efforts, and we have already been briefing delegation staff about the contents of the waiver. I think as we move forward, we would like to do a more concerted kind of community-wide effort in terms of trying to get congressional support, but then also just federal support for this. And so we'll be developing that, I believe, in the next month or two, and we'd be more than happy to have your assistance as legislators or any folks who are in the audience.
Representative Hamilton? Okay, thank you, Mr. Godfrey. And Representative Murphy? Or,
Thank you, Madam Chair. And
yeah, thank you.
Thank you, Madam Chair. And I think this is a question for Ms. Wood. There were public comments submitted to the department regarding the level of care 1115 waiver, and I am wondering if those comments are available for us to review as well.
Ms. Wood?
Madam Chair, Representative Murphy, yes, they are available on the DHS website. I believe they've gone up as of yesterday, and so they are available.
Thank you.
And Madam Chair,
Thank you, Ms. Wood.
I would just say, Madam Chair and
Mr.
Representative Murphy, that also DHS's response to those comments is available on the web as well.
Thank you, Mr. Godfrey. Representative Fritz?
Thank you, Madam Chair, and to Mr. Godfrey and Ms. Woods, thank you for bringing this information to us today. And I just wanted to comment on Representative Hamilton's request also from all of us that we contact our congressional folks, which we have done and will continue to do. And I know that Representative Franken has been very helpful and very open to this and understands the issue. Believe me, but it would be good to continue that conversation, and I promise to do that, and I hope we all do at this table.
Thank you, Representative Fritz. Representative Loeffler?
Thank you, Madam Chair, and thank you for pursuing, I think, increased independence and more appropriate personalized planning for serving some of our vulnerable citizens. I like that your conceptual framework has the biggest share for community and family supports. But those are typically provided by local nonprofits, counties, cities, and churches, faith communities, and they're all struggling right now. And so I'd like to hear how you're involving those partners in helping us to plan this system, because I think if you don't engage them, you may make some assumptions about capacity that may not be there.
Ms. Wood?
Madam Chair, Representative, some of those individuals have been participating with us as a part of the work groups that have been involved in shaping the concepts here, and so I think that's kind of our first check-in with them. As you probably know, we have been working with local community groups for some time around changing and reshaping some services,
Thank you.
and that work
Ms.
is going to
Wood.
continue on.
Right. We have another testifier, and so all right. Did that get your question answered, Representative Loeffler? Okay. Thank you very much. I know we have more. We have a very full agenda. And thank you for testifying today, Ms. Wood and Mr. Godfrey. Appreciate it very much. And any more questions, we'll be sure to contact you. Yep.
Thank you. I think the Commerce is coming down. They can come and get set up. And I've been involved a fair amount with this waiver business too, and I think the future is in that. We certainly want to make sure that there's safe level of services, the capacity is there, but we absolutely need the flexibility. And the more we can do that on a bipartisan basis, the better. And even in terms of Representative Hamilton asked a question that I had to leave to not hear the answer, but the more we can help them lobby on a bipartisan basis with our congressional officials, the better, I think. So, Mr. Rothman, are you here? Oh, you're coming. Okay. I can only feel so much dead air time here, you know. Oh, he's outside. Okay. And Ido. Okay. And there's some written testimony from Ido in your packets, and that actually speaks to process and conclusion. And so, anybody else want to say something about the waiver process? Or please, anybody in the audience want to testify? Anyway, so we now have an hour to talk about the exchange whenever we get talking about it. We did invite the non-finance members of the health committees to come as well, and offered them welcome, Commissioner. Have a chair. We offered them the privilege of the floor as well, and so that was offered to all the members who were only on the policy committee. And because these 3 reports we did today will not be covered in the policy committee or the reform committee. Well, Commissioner, welcome to the committee.
Thank you.
Yeah, we saved a bunch of time to talk about this thing. I know there's so little controversy, and it would probably be a 5-minute report and blank out of here. But we thought, just in case there's a few questions.
That's what I thought, too.
You were thinking, yeah. Mr. Reich, welcome to the committee. Introduce yourself. I know you have a presentation, so I think I'll let you go through the presentation. And then, is that what you'd like?
Yep.
And we can ask questions. And
Yes, Mr. Chair, that'd be great. My name is Mike Rothman, Commissioner of Commerce, and today talking about the Minnesota Health Insurance Exchange Task Force and the recommendations. You should have at your tables a deck, really slides. We'll go through them as well. Plus, I believe you have the actual report of the task force. So let me just dive right into it. A little bit of background. What we did was establish this task force to advise the Department of Commerce. It was done through the Secretary of State's open appointment process back in September. We sought appointments, I think the deadline was September 27th, and sought 15 members. Our reach was wide. We sought consumers, other stakeholders, including health plans, brokers, legislators, and the appointment term was for 2 years. We got the task force up and running, selected the members in October, and then had our first meetings, which I'll show and talk about a little bit later, in November, December, and January. One of the first things that was readily apparent was that the task force had a lot of work to do. And we established work groups that tackled a bunch of various areas, and I'll delve down into those as well. We had over 100 applicants who sought membership on the task force. It was a terrific, absolutely terrific response. Many experts, many people from all over in the stakeholder groups who have come forward to help the task force in the work that we have underway. It included employers as well, folks from the labor community. Talked about the providers, the insurers. We also had representatives for Medicaid, agents and brokers, all with the experience that helped navigate us through some of the complexities of enrollment in the public and private health care markets, and as well legislators. The membership of the task force is set out here. Let me just run through it. As you can see, terrific and exceptional folks who have come forward and helping on the task force. So we have Sue Abderholden, the Executive Director of the Minnesota Alliance on Mental Illness, Alfred de Babington Johnson, affectionately Babington, CEO of Stair Step Foundation, Danette Coleman, Vice President and General Manager at Medica, Phil Cryan, Health Policy Specialist and Organizing Director at SEIU, Mary Ford, an attorney, formerly General Counsel at Alina, Dory Bolo, CEO and Board Member of Open Cities Health Center. Also had Robert Hanlon, Founder and President of Corporate Health Systems, agent broker representative, Roger Cathall of Cartesian Solutions, a doctor, Phil Norgard, Director of Human Services from the Fond du Lac Indian Tribe, Stephanie Radke, helping us from the county perspective from Dakota County, Daniel Schmidt from Great River Office Products, a small business owner and representative from the Minnesota Chamber of Commerce, Senator Ann Rest, Senator Tony Laurie, Representative Joe Atkins, Representative Huntley, and then three commissioners, Health, Human Services, and myself. The purpose of the task force and key critical component of what the responsibilities of the members are is to advise on the following items. Advise the Department of Commerce, advise the public, advise all of us on these topics and more. The size of the small employer market, question of merger of the individual and small group markets, provisions to avoid adverse selection, risk adjustment, regulatory simplification, cost, quality satisfaction rating for insurers and health benefit plans, the Navigator program provisions, that's the agent and broker provisions, but also county workers who will help folks navigate through an exchange. The question of long-term governance and ongoing funding mechanisms. So what we did at the outset was split up into technical working groups, 10 of them. The 4 at the top were launched immediately. The remainder waited, but we are in the process of filling those with members to start tackling some of these other issues as we go forward. So the first 4 are adverse selection and encouraging market competition and value. The second is the navigators and agents and brokers work group. We had a governance work group of technical experts, a lot of attorneys, and then the finance work group. From there, these others are also launched now. Tribal consultation, IT and operations, individual eligibility, small employers and employees, measurement and reporting, and then outreach, communications, and marketing. We established a very aggressive agenda starting in November 8th. I want to walk through sort of how we did it in the process, what we tackled and what we did up until we came up with our recommendations. First meeting, charge, process, and structure. Spent a lot of time discussing what our goals were and how we were going to tackle the immediate tasks. The exchange, we did an exchange overview from staff at a very high level, what it is, what its purpose, what requirements are, and then we had the discussion of the key exchange issues. In the next meeting, we had a presentation by Gruber and Gorman, actuarial and economic experts who did a model based on and using some of the funding we received on what the economic impact is in the health plan marketplace, to the extent and when an exchange would be put into place. Discussion also on the recommendations and what our timeline was, or is. On December 7th, We discussed, had a work group discussion on adverse selection, and then the IT prototypes and some public feedback. Just a few seconds on the IT prototypes. We put up on our website these prototypes. They are samples and proposals from the private companies, vendors, interested in working on components of the exchange. It was done under and in response to an RFP that we put out in the fall, asking for, proposals and visions about what they could do in terms of helping build out the exchange. So if anybody's interested in that, those are available and can be seen. We're currently in the process, the department is currently in the process, the exchange staff, in finalizing their decisions on that. The next meeting on December 21st, we went up to St. Cloud. That meeting was focused on navigators and agents and brokers, long-term governance, and the presentation on financing. Really sort of high level, what are the issues, what are the pros and cons, and some of the issues that each of the groups were talking about as they formulated recommendations and came forward with those to the full task force. On the 10th, we had an initial discussion of the recommendations in those 4 categories. On the 17th, we went to Minneapolis and had a terrific discussion about health disparities. And it's actually a broader topic that crosses all of health reform, but focused on what the exchange might be able to do and accomplish in the disparities, focusing on the uninsured, who they are, and how to tackle some of those difficult questions. On the 18th, we met to finalize our recommendations and voted on these 4 categories, and within the categories, a series of smaller recommendations. When you look at the report, you'll see that a lot of the recommendations are very high level. They're meant to be guidance and for conversation and discussion, but also to guide and inform the public on what they think is the best way to proceed. I should say this too, that the task force strove very, very hard to achieve consensus. So all of the items that come out of the report are consensus items. Under adverse selection, for example, we talked about recommendations to ensure a well-functioning market that provides a level playing field and encourages greater market competition on value. There are a series of other adverse selection recommendations in the final report, but I don't want to get into all the details, but happy to if there are any questions. On financing, the recommendation primarily came out to ensure a fair and equitable long-term financing that would start in 2015. In governance, the recommendations primarily focus on a sustainable governance model to be responsive and accountable for what the exchange is doing. And in the navigator agent bucket, that category, the focus was at a very high level again on recommendations to ensure that all consumers and businesses are served by a Minnesota-made exchange and will get the assistance that they need and want from the exchange. So going forward, I had indicated we had tackled those first 4 work group questions. The remainder of those are still are in the process. The working groups will be asked to meet once their membership is finalized, and we will continue to have that work going forward. I should also say that the initial 4 work groups will be ongoing. They addressed some of the major pieces first, and there is a fair amount of work that they will be also looking at going forward. Those meetings are public. We have always had public comment, and if there's anybody interested here at all, we make those meetings available for comment in public. We welcome that, and we welcome the opportunity to work with the legislature this year on any exchange discussions. So with that, Mr. Chair, I would say that's the overview, primarily what we've done and where that task force is, and happy to discuss that and any other questions you might have.
Oh, any other questions? I appreciate that. And actually, just dawned on me, I don't know if you've been to our committee before. You've been to the Reform Committee a number of times.
I've been to Representative Gavel's committee.
So this is like a pretty good day for us. I think maybe you said hello one time, but I don't, maybe that was...
We've met.
I know that, but I mean in a formal committee setting. And we did allow some good time for the discussion. I see Ms. Todd Malmoff is here. Maybe, if you don't mind, if she joins you to sit there and get John out of there. Yeah, he's happy to flee. Yeah, he's happy to trade places. He's a happier guy now than he was before. Anyway, they always steal our good staff to the departments. Anyway, but it's no secret to either of you, including John, three of you, that this is a topic very controversial in this room, and probably the bill that you're bringing forward wouldn't pass this committee, even though I co-authored it in an effort to try to create a dialogue and some interest in it. I'm grievously concerned with some of the elements of that bill that I co-authored, and I'm just to tell you that, so I'm trying here. And, in any time that something passes any legislature, in this case Congress, by 100% to zero, it's going to be fraught with controversy. None of that's news to you. I'm just reminding you of the obvious, and you knew that already. And so there'll be a lot of questions, and hopefully we can be respectful in this. And again, we'll try to share the sides on the dialogue. We all agree that we want to try to help keep healthcare affordable and serve a lot of people and all of that. But I just have a couple questions off the top of my head for the project, and we might get into some philosophy stuff. I'll try to keep us on the topic, but members can express their views as they like, of course. I realize the report and the bill is very vague on all kinds of key elements, like where you're going to find the money. What do you think it's going to cost? I know the connector in Massachusetts was a couple of % of the market. Do you have an idea where we're going to land on that? Half, 1%, or do you have an idea yet?
Not at this point, Mr. Chair. Let me say this in terms of the funding. Right now, we are operating with implementation dollars from the federal grant program. So the initial dollars that go in are based on the $4.2 million we received on a planning grant, plus initial tranche of establishment grant funds, and applying for the additional funds. We had last year in our biennial budget requested the authority to receive and spend those funds, receive that authority, and a lot of the dollars that go to planning and implementation will come from those federal dollars under those grants. Going forward in 2015, the task force does have a few recommendations in there. It's to make sure that you can take a look at them, but to make sure that it's sustainable over time, that we look at all sources of potential funds, and then to also look at ways in which to make sure that there's an equity built into those sources. Those are high-level points, but at the end of the day, back to your question, we're still in the process. The key components of that cost is IT maintenance going forward, most likely, and then issues with respect to compensation and the navigators, in the navigator side of things, plus other things. So the task force and our staff will be looking more closely at that for 2015 and beyond.
Okay, I'll limit my questions to only two more, and then I'll share the time here. In terms of navigators, did you discuss, or what do you foresee? There's 40,000 agents across the state. What's going to happen to them in this system? Are they going to be all the same as they were, a little disrupted, or done? What do you think?
Let me step back.
Some other choice. I'll give you a choice D.
How about if I pick D or E, Mr. Chair? Our vision of the exchange I think I should say the public's vision should be this way, that we would like to have the best-made Minnesota exchange that we can. We have the freedom to choose that and to build one that works for Minnesota. We have a unique healthcare system, as you know. It's different than most, if not all, other states. And I've said from the beginning, in talking to others that have worked on these projects, that in order to make an exchange function and function well, you need all the stakeholders to help build it. And that includes agents and brokers. It includes the plans. It includes consumers. We need to have these are good questions because we need clarity on what this will do. In the work group, we brought in agents and brokers to talk about these questions. The beginning discussions are around how does the public enrollment process work? How does the private enrollment process work? How does it work for individuals with an agent in the private marketplace, and how does it work for small employers? So there's fluidity to it and how it gets implemented. We have choices that we can make for Minnesota. And the most important thing is that all have an opportunity to have that dialogue and discussion to figure out what the best way is for the marketplace. But we do not envision it to be one where there's no place. I think it's very critical we do, especially for the small business marketplace.
Thank you. And my last question from Ms. Todd Malmoff. Nice you can be here. And over the last year, I've become very impressed with how much you know about stuff. And so you and I don't agree on a whole lot of things. Now, we agree on many things, I'm sure, but on this one we don't quite agree on a bunch of it. But can you tell me your best view of what the federal version that would be imposed upon us would be different than what we're looking at? And I realize they don't know either, but can you give me a hint of what sort of differences there would be if for some reason the money, you can't get the $16 million or whatever it is, and everything just would stop abruptly?
I think there's a couple of key differences there. We've started to hear some initial things from the federal government as to what they're planning. I think one of the key differences, back to a point that Commissioner Rothman had made, is that Minnesota is very unique in what it is that we do, particularly on the regulatory front and how our markets work. What makes it difficult to have a federal exchange in Minnesota is that there are regulatory provisions affiliated with an exchange in the law. And if you have the federal government enforcing those regulatory provisions through a federal exchange, that could make market functioning within a state, particularly Minnesota, a bit interesting. And I think there would be concerns about how regulations are enforced, the consistency of them, and whether you would truly have a level playing field that's there. I think some other potential concerns that there would be around eligibility and enrollment. For example, exchange is responsible for determining eligibility and for Medicaid and other programs, and just the intersection with that of state programs, I think, would be a little bit of a challenge.
I appreciate it.
Mr. Chair, may I also?
You have to say your name, Ms. Todd.
Oh, sorry. For the record, my name is April Todd Momla, the Exchange Director at the Department of Commerce.
Thank you. Commissioner?
Mr. Chair, I've said this many times. I believe it's in all of our best interest to make a Minnesota-made exchange that works for Minnesota rather than waiting for the federal solution. And while we're keeping an eye on that, we're also focused on trying to find the freedom to choose what we want here in Minnesota.
I appreciate that. And the reason I asked the question is I asked the new CMS fellow from Chicago that question. He says, we'll let you know in the middle of 2013 when we start imposing it. And I thought, it would be helpful if we knew what was coming. It might help the dialogue to be furthered. Representative Slauer.
Thank you, Mr. Chair. Just to follow up on your line of questioning, I was in the meeting with the Region 5 guy when you asked that question.
Oh, yeah.
You know, it's sort of this whole debate about what happens if we let the federal government do it and we don't do it. Mr. Chair and members, several of us sat on the different task forces. Representative Loeffler was on one of them. Governance. I know Representative Murphy was on one. I was on finance. And so we've been learning about this. And I think one thing that was unfortunate is we didn't have any Republican members on those subcommittees for those task forces, because I think it really would have been helpful, because we're learning about it. And one thing, so my question would be on the financing one, boy, was it complicated. I mean, that's the first reaction. We all know this is very complicated, but when you get people, the words that kept coming up in our group were self-interest. people that have a real self-interest in doing well in this, the plans, the brokers, the chamber, are all there. And then we had a couple of people that didn't have any particular interest, is trying to sort all of that. And then my understanding is you also, at the same time, we're putting in all the sick people into the exchange, right? Because MSHA and everything else is going to be in there. And so you're going to have people that have to have insurance. Do you have any recommendation on or any thoughts on how to make it succeed? I think, Mr. Chair, from my viewpoint, I hope we design it, even if we can just do a simple version, because I think we do want to have control over it. But I worry about this whole idea of the level playing field, the whole idea of equity. It seemed like everybody in the room had their own thoughts on how they wanted to do it, and they wanted it their own way. And quite frankly, I think there were a lot of people in the room that didn't really care if it succeeded, if it was designed to fail, because they would benefit from that. So any thoughts on that, Commissioner?
Commissioner.
There's a lot of questions in there.
And let me just comment before you answer the question. We have 35 minutes, which will go quick. And so, and just if you can keep your questions out, everybody's fine so far, but just as we bear in mind that there's a bunch of people who want to ask questions, and we could spend 2 more hours on this, which my CA says I can't do that. So go ahead, Commissioner. So maybe a shorter answer.
Mr. Chair, Representative Slawik, those are very good questions. My advice to all of us is to keep it as simple as possible. Keep it simple for the consumer, keep it simple for the businesses, and to do what we can to break it down into digestible bits so that everybody can understand for themselves what it is. There are a lot of complexities, but the way you can look at it this way: when you hit on the brakes in your car, they're very complicated products, and they're behind the scenes and under the hood. The complexities are there. They're not insurmountable, and that's why bringing all these people together to work on them as experts is so important. I also believe that if we do pull all these stakeholders together and strive for consensus and tackle the problems, we can get there. We did a really good job to get to what we've done so far, and I think with their guidance we should be able to do it. Here's where we don't really have an option, which is that by January 1, 2013, Minnesota needs to have a provable exchange, one that can be certified by HHS and implemented. And we're focused very, very much on achieving that, because if we don't, then there will be a federal solution that will be imposed on Minnesota. So we need to keep the eye on the ball. And I've also said this: I'm willing to come to the legislature every day and work with everybody and have an open discussion. I welcome that, and I will from here on. And I think we've had an open dialogue to be able to do that. So whatever we can do to help.
Thank you. Representative Gavel.
Thank you, Mr. Chair, and I want to thank Commissioner Rothman for being here, and April, thanks for being here. We've been in many different forums talking about this. I have probably 20 questions I'd love to ask in public about this, but I'll pick just a couple. In all honesty, I'm concerned about a bit of political pantomime here. I mean, we had a good task force, a good group of stakeholders that produced what I think are some very general recommendations that have been turned now into a bill here in the legislature that I think pretty much gives carte blanche to what's already been going on for several months, and that's that the Dayton administration has claimed control over $28 million of federal funds, and nobody's filing lawsuits over that. So you've got control, you're building something, and you and I have had private conversations about this. We'll continue to. But I think we deserve, if the goal really is to have a Minnesota-made exchange and have all the key stakeholders, including the legislature, engaged on that, I think we need to have a much more transparent dialogue about what is being built. What's being built with the money? Does it, in fact, meet Minnesota's needs? What is it going to do to Minnesotans long term? What is there going to be? What is their experience going to be? If I have a particular policy right now, will I be able to do the same thing 2 years from now or not? What will my experience be in the exchange? How will it be governed? What governance structure are we putting together? There are so many details that will dramatically, and I can't underscore that enough folks. The reason this whole issue is so controversial and so important is that it will dramatically change the way that Minnesotans get health care coverage. Now, some think it's going to be fabulous, especially if it follows the ACA to the letter. Many others are very concerned about the long-term impacts, particularly in terms of cost and commitment for Minnesotans. As this is being built, we need to know, not just because it's about the legislature versus the governor or one group versus another power-wise, but because if we don't get it right, we will all pay for it for years and years to come, and that's my deep concern. So I guess maybe what I'm asking is more of a challenge. I could ask questions like how are we engaging meaningfully with the legislature, particularly the majority, in discussing how this thing gets built, but we do need to have that transparency of what's being built, not because it's a desire to throw atom bombs at it, but because we need to know so that we get it right. And there are alternative ideas about how an exchange might be created, or maybe not a formal exchange. There are many other mechanisms to getting to some of the same goals that we need to talk about if we want a truly Minnesota exchange, or a truly Minnesota solution would be my preferred term. So I just challenge you and encourage you and invite you to really meaningfully engage with us. I think the task force was a nice step, but I don't think the results are terribly strong, and I don't think the bill coming forward in the legislature right now that supposedly came out of this task force is going to do a lot to help us.
I'll take that as a statement. Do you have a question, or is that? I appreciate it. Okay. Well, I appreciate it. I know you've had a lot of dialogue with the commissioner already. So, Representative Franson.
Thank you, Mr. Chair. Commissioner Rothman, this question may be directed toward you, I believe. But first, I just want to state that I don't believe that Minnesota should lend a hand to the federal government in constructing a health care insurance exchange. Instead, it should look to, stand strong and smart in the company of most of the nation's states in battling against his disastrous federal health care law. And as stated in The Art of War, victory comes from finding opportunities in problems, not creating new ones or furthering those of the past. And with that said, I think that the words Minnesota model are a bit deceptive. Could you please tell me what specific parts of the federal law and rules does the exchange not have to follow? I believe that, according to the Kaiser Health News, that the word require shows up 811 times. And Commissioner Rothman, in the Senate hearing, you didn't know about that specific number.
Commissioner.
Mr. Chair and Representative Franzen, I'm happy to discuss, and actually going back to the last statement, all of the exchange stuff with folks. At the end of the day, Minnesota has the option of choosing a Minnesota model, a Minnesota marketplace for itself based on its own opportunity. And if we don't by January 1, 2013, then there will be a federal option. It's a good question. There are 16 states total now that are looking at or have legislation in place, 2 by executive order and 1 as an executive agency action. The structures are varied. Public-private partnerships, state agencies are doing it, and nonprofits in some instances. There are 25 states that are studying and planning it in addition to the others, and there's really very few that are not. And I just would encourage everybody to keep an open mind to the freedom of choosing for Minnesota what we would have. The exchange is meant to give consumers the choice, increased opportunity, and access to insurance, and to have them get the information so that they can make those choices.
Thank you. Representative Franson.
Thank you, Mr. Chair. Commissioner Rothman, I do not believe you answered my question. Governments do not create marketplaces, they destroy marketplaces. What specific part of the federal law and rules does the exchange not have to follow?
Commissioner.
Mr. Chair and Representative Franzen, when you look at the ACA, there are all kinds of requirements under it, and I'll concede that. I think we all know that. In general, what is a requirement, what we have to do are laid out, and we will comply with those to the extent that we should. But it also creates some flexibility for us to build our own exchange, and I think that that's where we should focus.
And
I'm happy to talk, Mr. Chair. I'm happy to talk about those requirements too.
yeah, well, I think that time's not going to allow that. But I was just thinking if there would be, if you want to actually provide us some follow-up data on what you perceive to be the 16 requirements or 800 or whatever the number is for requirements, and that might be productive. And Representative Franzen, if you want to ask a different kind of question, that would be.
Mr. Chair.
Then I'm going to move to the next questioner.
Mr. Chair, if
Yes,
I might. Let me just offer to provide just sort of the general guidance that does say HHS has on what requirements or things that should be included in an exchange.
You'll provide that?
There is a document.
Okay, I think a document would help. Representative Franzen, you still have a question? Yeah, go ahead. Yeah.
Thank you, Mr. Chair, and I appreciate that, Commissioner Rothman. Thank you so much, and I hope, Chair Abler, that we can do a longer discussion on this exchange at a later time, since this is very important discussion here. I've got one final question, and I understand that you took public comment on the online exchange prototypes, and how many comments came in, how many supported and opposed, and will those comments be made public?
Commissioner.
Mr. Chair, Representative Franzen, we'll get you that information. We'll supply it to you.
Thank you. Representative Liebling.
Thank you, Mr. Chair, and this is very interesting, and I was going to ask sort of a more in-the-weeds question, but I want to back up a little bit and just say, first of all, I appreciate Representative Gottwald's comments here, because, there's some irony that the presentation before this one was all about getting waivers from federal requirements. How do we get out of things that feds want us to do? And here, we're talking about designing something for Minnesota so we don't have to do what the feds are going to tell us to do. Seems pretty obvious to me that we want to do it the Minnesota way. And this idea that we don't want to cooperate because we didn't like the law that was passed, frankly, and I've said this before, there are things about it I don't like. It's not the model I would have chosen, but that ship has sailed. So we basically have two choices here. We can either do something that meets our Minnesota needs, and as Representative Gottwald says, try to do it the best we can, or we can wait and have it imposed on us, and then maybe for however many years we'll be looking for waivers. And people will be saying, oh, why are the feds telling us what to do? I don't think we want to be in that situation. I want to go back to Representative Abler's sort of opening on this, too. This was a law passed by only one side. I don't think that, I think President Obama worked very hard to incorporate ideas from both sides. And I think he did that. Maybe that's some of the reason I don't necessarily like all of this law, because it actually includes a lot of more Republican ideas than I actually like and am comfortable with. But he did that. Congress did that. There was a huge attempt to get consensus. And from my point of view, I just have to say I think that one of the sides decided that they just weren't going to go for it no matter what was in it, and that's why we got what we got. Now we may be in that situation again here in Minnesota. I hope not. I think that we have here some rational voices who want to make this work, given that, federal law is federal law. When they pass it, it's the law, and we're all Americans, and we're all sworn to uphold the law to the best of our ability, and this is part of that. The question I would ask, I'm not sure if Commissioner Rothman can answer this, or if maybe if staff can, but I seem to remember when I was newer in the legislature that Governor Pawlenty had a proposal for an exchange. And I don't really recall if I even knew what exactly that was. But I just would like to ask if I'm correct about that, and if indeed in Minnesota there's been an attempt to do something like this. How is that related to what we're trying to do now?
Yeah. Whichever of you would like to comment.
Mr. Chair, Representative, the answer is yes. Governor's Task Force Health Reform 2008-7 did come forward with a recommendation to and proposed a an exchange for Minnesota. So well before the federal conversation. But yes, it is. I've read it. I can't quote it to you, but it calls for an exchange for Minnesota.
Representative Liebling, Governor Romney had that. It's ironic. He's promoting the same governor for president, so there's something there. But it's so they're obviously friendly about this. I was one of the opponents of that too. So Representative Huntley, I did not agree on that. We agree on so many things. We found something we disagreed on there, and it was controversial at the time, and we moved away from that as a proposal. Representative Liebling.
Well, thank you, Mr. Chair. But I guess my point here is just that, if we want to say that the whole idea of an exchange is something big foreign thing opposed from, the people we don't like on the other side, it just isn't true, folks. This was something that came from Governor Pawlenty. Now, you may say, oh, he's a moderate, I don't like him, whatever it is, but this shouldn't be a partisan issue. This should be about, there are different interests in this. Granted, somebody's ox is going to be gored all the time in anything we do. And we ought to be working on this together and trying to make sure that we get something that's going to work for our state, as I hear Representative Gottwald wanting to do. And that's my comment. Thank you.
Well, I appreciate that. And I didn't like it because I thought it was a bad idea, unnecessary. We had a great, robust network of 40,000 agents who serve on every main street in town, and if we could get them some capacity to add people into state programs, I thought we'd be done for free. That was my interest in it. And so we discussed it then, and it wasn't quite so fervent because I don't know if it was like a bill, but Representative Gottwald to this point.
Just quickly, I think I appreciate your comments, Representative Liebling, Mr. Chair. It's also important to understand that not all exchanges are created equal. There are many different concepts of what an exchange is and the ideas that they're trying to address and the problems they're trying to solve. So, that's really important as we talk about this from a policy perspective. My comments were meant to go at it is vitally important that we get the model right, whatever we do. And part of my frustration is that we're not working bipartisanly. Right now we have the governor and his administration, and I'm just being honest about this. They have the money and the authority to move ahead with some model that we don't have all the details about. So I don't know whether it's a good one that I can support or not. I have no idea. And I'm optimistic we'll do something to move forward the issues we're trying to address through legislation at some point. But in any case, if we're moving down the road fast, and I've heard that said that we need to get this addressed in time, then if we mean bipartisanship, then let's meaningfully engage honestly and openly in an open dialogue about what we're building for Minnesotans. And I don't think we have that right now. We just don't have that right now. So aside from the opposition to the ACA, I do have one technical question that's really important, and I need to ask it. Commissioner Rothman, Mr. Chair, I understand that the ACA right now does not authorize a state exchange to distribute subsidies, public subsidies. And I'm wondering if we need state legislation in order to make that happen for a state exchange if it were created. I understand that it may be one of the places where the ACA does not empower a state exchange, and I'm just wondering if you can speak to that, either you or Ms. Todd-Melimoff.
Sure.
Whichever of you.
Mr. Chair.
Mr. Todd-Melimoff.
And Representative Gavel, if I can, I just wanted to comment on the discussion, too. My approach to the task force and to doing all of this is to keep the door open and to talk with everybody. And when we did the task force, invited both sides of the aisle to join us. And in all of this debate, I recognize there's practicalities and everything, and I just want to make sure that we have that open dialogue, however we can achieve it. I welcome that. I sincerely mean it. I'll work on this with you on a daily basis or whatever, and then get to that clarity or the details that are necessary. But at the same time, this is a lot of the details in terms of how do the subsidies work, the tax credits. The task force work groups will be delving down into those specifics, and again, those are open. So whatever we can do to get those answers for you, we're happy to provide to you.
Well, okay. Mr. Chair, thank you. And Commissioner Rothman, I appreciate that, and I know you mean that. We have met privately about this. We've been in public forums about this, but we still haven't seen what's being built yet in great detail, and I know I've asked that of you, and I'll continue to ask that of you. So the invitation is fine, but at some point we need to get down to the substance. And then these details are vitally important, and this is one of my concerns, is that CMS is not giving us good direction. I think you've shared that frustration too. Given the timeline, that we need to have some things in place by certain points in time, not knowing the answers from Washington and knowing even few answers here in Minnesota concerns me a great deal, given the impact that this entity is going to have on Minnesota's healthcare marketplace. So we need to get down to these details. We need to get specific answers. We need to know the model that's being built right now today with the money that we have. And we just need to have some real transparency about that.
Mr. Chair,
Commissioner.
Representative Gavel, let me just comment for a second about this. What work has been done to date is pretty transparent in terms of the task force. We've laid that out. With respect to where we are at the department, as you all know, there was legislation introduced last session. There were 2 bills introduced. One was your own. We monitored and would have invited any of the discussion. In the absence of having that direction, we were put in a position of needing to move the ball down the field, and to do so with the federal grant dollars and all that. The federal grant dollars that we have is, at least at the initial stages, is really focused on a couple of buckets. One is the IT infrastructure. The IT infrastructure is, in a way, agnostic. It has to be in place regardless of which way we go. It has to be in place and has to work with, the Medicaid enrollment, eligibility process. The questions about, is it going to be a public-private partnership? Is it going to be, how are we going to put a board together and all that stuff? That's different. And then what's under the hood, we've talked about, and happy to continue those discussions to get clarity for all of that, and happy to do that.
Well, thank you. It's a popular topic. We have Lomer is coming up. We have Anderson, Hosh, Kiffmeyer, Franson, Patrick.
Okay.
So
let's keep going.
You're popular. So if you can just maybe do one question each, and this has been a very good dialogue. Just our time is finite. So Representative Lomer.
Thank you,
You
Mr.
have
Chair.
1.5 questions if you want. Everybody else got.
Well, I have all these questions, and people keep kind of asking them as we go along here. But I want to clarify. I know that you've been given the executive order and you've developed this exchange, but I'm just wanting to make sure I understand. Is there a law, a specific law that allows us to implement it, or are you saying we as the legislature are to do that? Is that correct? We will give you that, Mr. Rothman.
Mr. Chair and Representative, right now, I guess this is the general question of what authority, where are we right now? You talked about the executive order. The order itself says that the Commissioner of Commerce shall design and plan, or design and develop an exchange. But then there's also the authority received in the biennial budget that gave the department the authority to receive and spend the federal dollars, the grant dollars, for designing and implementing an exchange. So that's the authority that we have, and it's focused on the design and implementation. There is also the question about authority. There's some uncertainty here. The question, if you take a look at what is laid out in terms of the high-level recommendations of the task force and where we can go, there's uncertainty there. But at the end of the day, by January 1, 2013, we believe that there's sufficiency to proceed so that we can qualify and get a Minnesota-made exchange in place and get us to that point. We would be at a point where we would work with the Attorney General in terms of what we have and what we can do to get ourselves over that threshold. But that's generally where we are.
Okay, thank you. Just a follow-up. We have a lot of discussion here about the Minnesota-made exchange, and we all are saying that we want to do our own thing. I guess my question is, do we have any guarantee that in 2014, when the whole entire ACA becomes in effect, that we will be able to continue to have the Minnesota, or will the federal government be able to come in? I mean, is there any guarantee that we'll keep the Minnesota exchange?
Commissioner.
Mr. Chair, Representative, what we can just say is that under the ACA, it allows states to develop and implement this. That we are given the opportunity to have it approved and provable and certified by the federal government to proceed, and we assume that having that certification and go forth, that's the direction where we would be going, and that's what the plan is under the law.
Thank you. Just, and we'll keep Representative Loeffler is next. But you said that we passed a law. Could you get me a copy of that section, the statute we passed that enabled what you just said, and circle it so I can read that paragraph that was passed?
Mr. Chair, just to ask a question back, are you referring to the budget request?
We said that there was authority to spend the money to develop an exchange.
That was a budget.
Remember.
It was a budget item.
Okay, I would be interested in could you just...
Absolutely.
Oh, in 2010.
Yeah.
It wasn't, you said last year.
We didn't.
2011. It was 2011, and it's in the 2011 budget.
Okay.
So we can provide...
would like to read it.
Absolutely.
I'm just surprised that would have been in the budget.
Absolutely.
So. Okay. Representative Loeffler.
We can get that to you.
Thank you.
Thank you, Mr. Chair. And, I think there's been a bipartisan effort over the years to try and get everyone access to affordable health coverage, because we know then less of that comes on the committee budget of this committee. And, there's been a couple of different tools. It's been the Minnesota Care Program for people who are working. But it's also been in terms of rate limitations on small business insurance, so that small businesses have the courage to jump in and they don't see the 50-60% increases that some small businesses have seen in other states. And it's also been by us promoting the use of what's known as the Section 125 plans, where both the employer and the employee get to pay for their insurance with pre-tax dollars, and the employer gets a little extra benefit because they get to not have to pay FICA on that portion of the premium. And it's my understanding that that's only going to be available to that Section 125 to our small employers if they do a group purchase through the exchange. And I didn't see, sort of much discussion about that. Is that something that's going to be taken up by your small employee work group that's coming up? Or how are we going to make sure that, because otherwise we potentially have premiums that would go up 20 to 30% if people can't do it pre-tax. And I just want to make sure that that's on the agenda as we develop that Minnesota model.
Commissioner?
Mr. Chair, Representative, thank you. I do recall you and I talked about this too, and it's an issue that the work group, it's a good place for the work groups to be taking a look at that, and how does that play. The issue, let me just step back and say this, that it's important for small employers to have additional opportunities, and what the exchange can do is reduce administrative costs. It can help tackle the affordability of insurance for themselves, the companies, and for their individuals in their businesses. And for that reason, do support and have supported the idea and concept of an exchange. The idea is to make it simple for them and to try to give them those opportunities. But it's a very, that question is important, and if April has some other further commentary on it, but it is one that we will take a look at in the work group.
Ms. Todd-Melma, do you want to comment?
Mr. Chair, Representative Loeffler, on the Section 125 issue, that there is a provision in the law that limits the use of Section 125 plans for individuals that would essentially somewhat similar to the law that had passed in 2008 that would allow an employer to just set up a Section 125 and their employees could put money in through it. Under the federal law, they're not allowed to do that in an exchange. But that does not mean that they couldn't use it for a defined contribution type arrangement or under a group coverage arrangement. That's still allowed.
Briefly.
Just to follow up, I thought, and tell me if I'm incorrect, I thought the small employer group purchase still qualifies for Section 125. And so it would have to be a group purchase on behalf of that small employer. Is that correct?
Mr. Chair, Representative Loeffler, that is correct, that it's a group purchase. But under the federal law, if there is an employer contribution, that is considered a group plan.
I think if you have more questions, you can discuss that. You're just going to confuse all of us about that. Representative Anderson?
Thank you, Mr. Chairman. I kind of have
It's about what other states are doing, so whichever person can answer this. Kind of, do you know of any other states that have submitted an exchange to the federal government, or in how many, and if you can even get back to us on that, and how many of the other states have actually had their exchanges turned down by the federal government? I've been told that several states have submitted them and they've been turned down. And also, how many have been approved by the federal government? Do you know that information?
Mr. Chair, Representative Anderson, we'll get you that information. We have a detailed chart as to which ones are going by legislation, by executive order, the structures that are in place that can help how many are looking at it. And again, all states are working towards that January 1, 2013 certification. So Minnesota, like others, are in the process of that open dialogue is to get to that point where they would be proposing themselves to be certified on January 1, 2013. But we'll get you the details of those.
So, Mr. Chairman, my main concern, too, is how many states have submitted plans to the federal government that have been denied, their plan has been turned down. I want to get that information, too, please.
Commissioner, I need that far along.
Mr. Chair and Representative Anderson, none have submitted their plans for certification yet.
Okay. Is that good? Representative Haas.
Thank you, Mr. Chair. And I appreciate the opportunity to discuss this issue today, and I think a lot of the questions are questions that can be directed back to us too, because as legislators, I think one of the things we have to do as a legislature is participate in the development of this exchange, even if we have a philosophical difference about how the exchange got to where it is today. There's a lot of things I think both sides of the aisle can support, can believe in. There's a lot of free market principles in the exchange. There was a mention of how many times the word require was in the Affordable Care Act. Well, I also have a little bit of information that the word may appears in the Affordable Care Act 1,186 times. And I think that shows us the flexibility that has been granted, too, in developing this exchange. Now, I'll give you credit. 2 of those Mays were the month of May. So it's actually 1,184 times that the word may is in the bill. But from governance to the way that we implement it is all up to us. And I hope that we can participate into developing this because the clock is ticking and it's ticking quickly. I have a large agricultural economy, and a lot of my farmers have to buy insurance on the individual market. And there's nothing more frustrating to them in trying to compare plans, to be informed, and to have transparency in the product that they're buying. An exchange is something that will provide that. So I hope we can move forward. I respect and I understand a lot of the ideological concerns that my colleagues on the other side of the aisle have. But the fact of the matter is, if we don't do this, the federal government is going to implement something in 2013 under the terms as we know it today. And we have a responsibility to the business community, to our constituents, and to many others to try to build an exchange that is best suited to us and which you can have your input into and try to quell some of the concerns or apprehensions that we may have.
Thank you. I guess that's another statement from the St. Cloud area delegation. Representative Kiffmeyer.
Thank you, Mr. Chairman. Commissioner Rothman, I appreciate your best efforts. You are assigned a job to do, and so are we. And so we're able to have that, and I appreciate your being here today. I think what's still a bit amazing to me, though, is, we're supposed to pass the bill to find out what's in it. Now it's passed. We're not always sure what's in it, but we're supposed to believe that it's better and cheaper and that the feds can be trusted, that we can do it our way. And yet you have all these other issues when we're asked about what will it cost, what does it look like, but there's an urgency. You can play ball any way you want, but here's the rules. And I think that's exemplified by the fact that there's certification. I think that tells us right there, if you have to ask the federal government and submit your plan, and they get to decide whether to certify it or not, then we know who made the rules and who's really in charge in this regard. IT is not agnostic. You have Apple and you have Microsoft. They both have operating system rules that are very, very different. They have a philosophy behind them. Then you have software, more rules. And so Between all of those things, I am not confident that the feds can be trusted to let us do it the Minnesota way. No matter our best intentions. I have not yet to find, especially when the IRS is involved on this also, and so many other heavy-handed federal entities, that for us to say, just trust the feds, they're here to help you, is a big leap in my mind, even though I recognize your best efforts. Thank you.
Thank you. I'll take that as a statement. Representative McElpatrick.
Thank you, Mr. Chair. I'm responding to comments, I think, or reacting to them that Representative Gottwalt and Lohmer and now Kiffmeyer have made. There are many people who are very concerned, and many of these people are medical professionals, that they will not have protection of their rights of conscience. And if we're developing a Minnesota exchange, what kind of assurance are you willing to give me that we as Minnesotans will respect the rights of conscience of our health care providers?
Commissioner.
Mr. Chair, Representative, the best way to answer that is to say we're working with providers. They're on our work groups and our task force. We have, with respect to all of these issues, taken an open approach to make sure that all voices are heard, that we hear criticism, and we're told about the concerns. My approach to all of this is that if it doesn't make sense, let's not do it. If there are concerns about the way the exchange is being implemented with respect to those questions, I'm open to hearing them, having a further dialogue about them, and to make sure that we address those.
And the last question, Representative Franzen.
Thank you, Mr. Chair. Folks, I'm looking at the forest for the trees here, and I believe that we are heading down toward a single payer. And a Minnesota health insurance exchange will be a single government site, thus leading to bigger government. In Massachusetts, health insurance for a family of 4 costs 33% more than the national average. Massachusetts and Utah have to change their exchanges to meet the federal law and rules. And with that said, Commissioner Rothman, today there have been a lot of unanswered questions. You have said that you will get those answers to us at a later time. I'm not sure if that's because the questions that we have asked you don't want to get on record. However, I would like to see that we are presented with these questions by end of business next week, if possible.
Well, and Commissioner, do you want to?
Mr. Chair, Representative Franzen, that's fine. And if there are other questions, I'm happy to come back, happy to talk to folks. And if you have more of our staff, just let us know.
Thank you. Commissioner and Representative, anyway, Ms. Todd Malmoff, it's a compliment. Been here so much. I think this is a good dialogue. I think that the time we had was, we tried to balance out the questions. I think everybody who had one got to ask one. And this is a discussion that will continue beyond today. I appreciate you coming today, and I appreciate all the good questions. Tomorrow we get legislation to work on. We're adjourned.